Welcome to AETCM, the emergency medicine channel. Today I will be presenting a case of a 58 years old female who came with alleged history of slip and fall in bathroom in her workplace with fall on outstretched left hand, and she had complaints of pain, swelling and painful restriction of movements of left wrist. No history of LOC, vomiting or ENT bleed. In initial 10-second assessment, patient was conscious, oriented and obeying commands. Primary assessment, airway was patent, there was no C-spine tenderness, breathing, chest movements were bilaterally equal, air entry was bilaterally equal, saturation of 99% on room air with respiratory rate of 22 per minute. Circulation BP of 140-90 millimeters of mercury, pulse rate of 96 per minute. Disability, GCS was E4, V5, M6 with pupils equal and reacting to light, moving all four limbs. Exposure temperature of 98.6 degree Fahrenheit. She had a pain score of 6 out of 10 and injection PCM, paracetamol 1 gram IV was given. A secondary survey, apart from the history, the patient had no allergies or she was on metformin for type 2 DM, and last food intake was 5 hours back. Head to toe examination showed left wrist swelling of 6 into 5 centimeter swelling with tenderness present with deformity, and painful restriction of range of movement was present at the wrist. Active finger movements were present. There was no sensory motor deficits and radial pulse was palpable. There are no other injuries. X-ray was taken of the left wrist. AP and lateral view was taken, which showed distal radius fracture. So we planned the patient for closed reduction with slab application. So we prepared the patient for procedural sedation for the same. First, we took an informed consent for the procedure, and we recorded the initial vitals, and we had connected her onto cardiac monitor with continuous saturation and pulse rate monitoring. And we had also arranged for other equipment such as suction, if any vomiting, in case of any vomiting or any oral secretions. We had also we arranged for the airway adjuncts, bag and mask ventilations, and also the intubation set was arranged, and also nasal and oral airway was also arranged. Then other resuscitation medications are also crash cart.
Oral airway here?
No, nasal airway.
Yes. What we are going to do is procedure sedation, right? You are not really going to completely sedate the patient to class 4 level. You are not sedating. So patient will always have gag reflux. The idea is patient should have gag reflux. Okay, fine.
And other resuscitation medications were kept ready for. And after that, the patient IV access was secured. And initially we had given her injection, MSet 4 mg was given, and after that we had given based on the weight around 60 kg we had taken with the dose. We gave midazolam, which was around 0.02 to 0.03 mg per kg. We had given around 0.02 to 0.03 mg per kg. We had given 1 mg of midazolam, and also we had arranged fentanyl. Fentanyl we gave 0.5 to 1 mg per kg. So we gave around 20. Initially we gave 20 mg per kg. She came in ASA class, which is the American Society of Anesthesiologists class 2, because she was known case of type 2 DM. And fentanyl we started at low dose at 20 micrograms. And during after that, during the
fentanyl
20 micrograms was given. Initially bolus was given, and after that, after around 5 minutes, we had started the procedure. During the procedure, she had complained of pain, and we had given another 10 mics of fentanyl, and there was no any drop in saturation, or the vitals was also stable. BP was also monitored, and there was no drop in BP.
Okay. When you say procedure sedation, what is the goal of a procedure sedation? What are you trying to achieve?
We are trying to keep the patient sedated with analgesic effect, pain relief, and anxiolytic effect also. To relieve the anxiety.
So you want
Without
sedation, you want analgesia, and you want amnesia. These three things. Why? Because you are going to do a painful procedure on the patient. So you don't want the patient to remember the painful procedure. So you want amnesia. You want the patient to cooperate with you. So when you say cooperate with you, there is a huge range of cooperation, from simple procedures to very complex procedures. Like a simple procedure like central line insertion, you just want the patient to cooperate with you, to doing a shoulder dislocation reduction or a fracture reduction. You want complete cooperation of the patient. Okay, so cooperation, the level of cooperation will determine how much sedation you want for the patient. And of course, analgesia. You want the procedure to be as pain-free as possible. These are the three goals you are trying to achieve, but without compromising on cardiorespiratory function. This is the cornerstone of procedure sedation, without compromise of cardiorespiratory function. Because when you compromise that and you have to give drugs to interfere with cardiorespiratory function or to stabilize cardiorespiratory function, you have gone into deep sedation. So that is what ASA class of sedations are, class 1, 2, 3, 4. So it gives an idea of how deep you have to go. So it depends. So you should clearly have an idea what is the level of sedation you want to achieve in a patient. And according to that level of sedation, the drugs you choose should change. So that is one thing you need to understand. Procedure sedation is not one drug suits all. It will change with patient to patient and scenario to scenario. So the drug of choice for a central line insertion is not the drug of choice for a shoulder dislocation, or a drug of choice for a LP, lumbar puncture, may not be good enough for a fracture reduction. So case by case, there and scenario by scenario, changes should be there. That should be incorporated. First and foremost, is procedure sedation an emergency procedure or not?
Depend on the procedure. As in, if there is for endoscopy and for emergency endoscopy.
What is an emergency endoscopy? You get a upper GI bleed. You know the patient has vomited a lot of blood. You say the patient is hemodynamically unstable, and you call gastro for a endoscopy. There is no emergency in it. We call it emergency endoscopy because they say it is not done in the emergency suite, in the endoscopy suite. There is no emergency in it. You have time. You got it. Procedure sedation is not an emergency procedure. You know a patient will require procedure sedation when the patient comes to your department. Patient presents with history of fall. You are expecting a fracture. You know this patient will require procedure sedation. Patient presents with, as you said, upper GI bleed. You know this patient might require endoscopy if HP is very low or BP is very low. There is no emergency in it. This means it's a planned procedure. You have time to plan for it. And one of the most important things you should plan is avoidance of aspiration risk. So even though keeping a patient NPO in emergency department is quite difficult, according to ASA classification, you know that the patient should be kept NPO for 6 hours, for 4 hours for clear fluid, breast milk 4 hours, 6 hours for clear fluid, 8 hours for food and other particles. And NPO should be maintained more than 8 hours if patient has consumed alcohol. This is not practical in emergency, because we can't just keep a patient 8 hours or 6 hours in emergency just to do a procedure. So procedure sedation has the name emergency mainly because we are assuming risk, but doesn't mean that we can't take precautions against it. So one of the first precautions you should understand is whether this patient requires procedure sedation or not when the patient comes in, and give an antiemetic. Ideally, a gut mobility agent, perinom, so that patient gut emptying will be faster. So by the time you come to the procedure, risk for aspiration will be much lower. Now, when you say risk for aspiration, there are two types. One is direct emetic action due to the drugs you use. Fentanyl, opioids can cause emesis. Ketamine you use, increased oral secretions can cause vomiting. So, increased risk of emesis, which has to be counteracted by centrally acting antiemetics like emicit, ondansetron, not emicit, ondansetron. But actually, risk of aspiration is mitigated by gut mobility agents rather than ondansetron. So, perinom is the first line drug you should give when you get a patient who requires procedure sedation. Similarly, asking the staff to keep the patient NPO from that moment helps you. Even 1 to 2 hours of NPO is much better than patient having some amount of water just before the procedure and coming to your table, isn't it? So these are the small things you should make sure patient is taken. Similarly, route of administration of drugs. That is especially important in age groups, pediatrics as well as adult. IM drug delivery is much more common in pediatric age group rather than in adult age group. For example, ketamine. Procedure sedation using IM ketamine is one of the most common procedure sedation methods used in UK for pediatric procedures, and they are pretty good with it. IM has nearly equivalent effect of IV ketamine. Only downside is it has increased duration of action and increased onset of action. So you need to clearly plan the procedure when you use IM drug, but IM is much more safer than IV. So route of action is another question you need to address before saying procedure sedation. The more time you have to deal with the patient, or if the patient is always going to get admitted, you can even give IM drugs, because even if patient is sedated for a prolonged time, if patient is getting admitted, patient will be under observation, isn't it? But if you want to sedate a patient and do the procedure and discharge, you can only give very short acting IV drugs. You can't sedate the patient and keep in your ER for 8 to 10 hours to wake up, isn't it? So these are the important points of selection of drugs you need to think in procedure sedation. Second thing, as you told, informed consent is very important. We need to let the bystanders know there is a possibility of mechanical ventilation due to either decreased respiratory effort or complications of drug, hypersensitivity to drugs. That should be very clearly told to the bystanders, because bystander will be expecting a speedy recovery and simple procedure, which may not go in that way. So that risk should be clearly told to the bystanders. Then, as you told, cardiac monitoring, emergency drugs, that is atropine, adrenaline, and one more important thing. For example, in this case, what are the drugs you gave? Midazolam and fentanyl. Other than atropine and adrenaline, any other emergency drugs you need to keep?
Noradrenaline.
Reversal agents. There are. This patient will quickly, you gave midazolam. Patient has gone into respiratory depression. Rather than intubating this patient, if you have flumazenil, you can revert the patient. So reversal agents is very important in procedure sedation. If you are using agents that can be reversed. If you are using etomidate, ketamine, can't do anything. You have to wait it out. But midazolam, of course. You can, if you are using high dose opioids, naloxone, very important. So reversal agents or antidotes should be kept nearby. You don't have to open it, but it should be available. Okay. Then what? Then airway management devices. As you told, airway management. How do you manage airway? For the procedure, how do you manage airway?
Initial airway, you have to make sure there are no secretions. Then,
Yes. Reduce secretions. If secretions are there, patient is having increased salivation. How can you manage that?
Resalivation, excretion.
Glycopyrrolate. You can give glycopyrrolate sub-Q doses. You can give glycopyrrolate as nebulization. That will dry up the mucosa. So secretions can be calmed down. Other than that, tongue fall, nasopharyngeal airway, isn't it? And along with this, the question comes oxygenation. Ideally, in procedure sedation, is oxygenation going to be a problem?
Oxygenation, if we start
You
oxygen,
do procedure sedation, patient desaturates. Why?
because of
Tongue fall,
hypoventilation, respiratory depression, hypoventilation,
respiratory
apnea.
depression, then
Apnea episode.
aspiration. But as such, lungs is not affected. It's not hypoxia due to absence of oxygen. It's the most common is inability to take it. That is respiratory suppression, respiratory effort suppression. The trigger may be there, but the muscular effort may be suppressed, or patient is going into oral airway or tongue fall obstructions. So tongue fall and oral airway problems we manage with nasal airway. Respiratory effort should be monitored when doing the procedures. That is the monitoring you have to do. It's not the saturation monitoring, because if a patient goes into respiratory not fatigue, respiratory depression, that is respiratory effort depression, saturation fall happens very late. So what you are looking for is adequate chest movements. Patient's respiratory effort, chest movements, whether the rate is coming down or the effort is coming down. That's what you are observing, not saturation level. But we can keep saturation level so that we understand what is happening. Okay. Similarly, to some amount of respiratory depression can be seen in many of the drugs, especially when you give midazolam. We can expect some amount of respiratory suppression. Similarly, propofol, when it is given in very high doses, it can cause respiratory suppression. So, it's prudent to keep the patients on external oxygen therapy, that is, external oxygen delivery should be given. So, ASA classification you told, similarly ASA guidelines are there, and European Society of Anesthesia guidelines are there. They tell to put the patient on NRBM, non-rebreathing mask with 10 liter oxygen before giving the first drug. So you decide on procedure sedation, start the patient on NRBM, 10 liter oxygen, start the procedure until the patient regains consciousness and is oriented and obeying you. You should continue NRBM 10 liter per minute oxygenation is what, external oxygenation is what guidelines say. Guidelines also say one newer thing, which is ETCO2 monitoring. There is non-invasive ETCO2 monitoring, capnography monitoring, which may not be available in all the centers, because even in very higher centers it may not be that readily available. In ER, it can be available in respiratory procedure rooms and all, but in ER it's very unlikely. But if it is there, well and good. So you can get a spike in ETCO2, you can understand patient is going into respiratory suppression. Okay. So ETCO2 monitoring and external oxygen delivery devices is very important. Similarly, for rescue oxygenation, now external oxygenation and rescue oxygenation is different. External is what we told, NRBM 10 liters. Rescue oxygenation is when you detect desaturation or respiratory suppression and you are interfering to maintain the ventilation of the patient. That is with
bag and mask
ventilation. Yes, bag and mask ventilation or even NIV can be placed, but usually we use bag mask ventilation because we are looking for a short period of time, not prolonged time. So bag mask ventilation can be used for that. So this is airway and breathing, this thing. Okay, so now comes to ASA classification. As I told, ASA classification is basically to let you understand what type of patients you are going to sedate. So basically, it is a broad classification. ASA 1 to ASA 6 is there. So it just tells you what is the risk of this patient developing a complication when you sedate the patient, or is the patient stable enough, what to say, whole body is stable enough to undergo sedation. So in an ideal situation, a ASA class 3B or a class 4 onwards is contraindicated for procedure sedation, and ideally should be taken for a GA sedation, general anesthesia sedation. Similarly, when you take procedure sedation, you should always think whether this patient requires procedure sedations or under GA. For example, polytrauma case has multiple injuries, has long lacerated injuries, multiple lacerated injuries, multiple fractures. So if you are going to do procedure sedation for this patient, you will have to do procedure sedation for a prolonged period of time with very high doses of drugs with multiple bolus doses, isn't it? Because multiple injuries has to be dealt with, which will be a bad call. Much more better will be GA, because in one setting you can finish multiple things. Otherwise, the total amount of drug used in that patient will be quite high, and patient will have synergistic and add-on effects later. So, question after ASA, the question will be, is the patient really requires procedure sedation or GA a better solution for this patient? For example, for extended radiological imaging, you have a patient with seizures or onset of weakness, you are going for MRI brain with contrast with MRA and MRV. Total duration you are looking at 1 hour 15 minutes and all. Procedure sedation is not a good idea, because procedure sedation, whatever drug you give, it's not going to act more than 20 to 30 minutes. That means multiple dosages. That means more complications for the patient. Better will be GA, especially in pediatric age groups. Okay, so just telling you certain scenarios in which you may have to take a call for procedure sedation versus GA sedation. After that, you decide, okay, it's all set, your preparation, everything is set, scene is set. Question of drug choice comes up. Now, the question of drug choice has two parts. One is safety part, another thing is what you are trying to achieve part. Achieve part, we told, depends on the level of cooperation you want from the patient and how hemodynamically stable the patient is. Second thing is what is the duration of sedation you want the patient to be. So if you want sedation for short procedures, ideal drug is a fast acting, short acting drug. It should immediately act as soon as you give, and the patient should come out of it within 15 to 20 minutes. So there are certain group of drugs that belongs to it, and then there are certain group of drugs that has slow onset and a short to medium duration of action for maybe a prolonged type of procedures. So identification of the duration of procedure is also very important. Now coming to drugs, what are the common drugs used for procedure sedation?
Common drugs.
What is the most commonest drug?
Most commonest is midazolam.
What you give? Midazolam with a opioid is the most commonest drug. Certain centers go for morphine, certain centers go for fentanyl. Fentanyl is much better than morphine in procedure sedation, not in other conditions, but procedure sedation. Fentanyl is much better than morphine, fewer side effects, much more faster action, much more less histamine release. So, fentanyl. So, as you told, midazolam, 0.02 to 0.03 mg per 0.01 to 0.02 mg per kg, right? So, if you are dealing with a 70 kilogram person, what is your desired dose?
70 kilogram, 1 to
0.7. 0.7 mg is your desired dose, which is very low. But what we have to understand is we are not completely going to sedate the patient. We just want minimal sedation. That is why the dose comes this low. But the problem here is certain drugs have very high distribution, fat distributions or third space losses can be very high. So that also has to be taken into account. Certain patients, if at all they are already have a chronic history of alcoholism or any other toxin, means recreational drug use, will be resistant to certain drugs. So that history part is very important before giving midazolam, because 0.7 mg you give to a chronic alcoholic may not have the desired effect because their body is used to midazolam. That part should be looked into. So midas you give 0.01 to 0.02 mg per kg IV bolus, followed by what is the repeat bolus dosage?
Repeat after 2 to 5 minutes, same point.
Say 0.01 mg per kg boluses can be given. Up to 3 boluses can be given. After that, we have to think about adding on a new drug for a synergistic activity. Okay. So, what is the negative effect of midazolam?
Midazolam causes respiratory depression.
Higher doses of midazolam causes respiratory depression. What else?
Then, if there is any kidney or liver dysfunction, the doses have to be reduced.
Yes.
Or will be prolonged.
Metabolism of the drug is highly dependent on comorbidities of the patient, especially if CLD is there. That should be taken into control. Okay. What is the other drug other than midas? What else is there for?
We can use for ultra short acting. We mainly use etomidate or propofol.
Okay.
Depending on the hemodynamic status, or in case of if there is a hemodynamic instability, as in hypertension, if the patient is having, then we can use etomidate. It is more stable.
Cardio neutral.
Cardio
State. It doesn't affect heart rate, it doesn't affect blood pressure. So, risk for hypotension after etomidate is very minimal, isn't it? What is the dose of etomidate for procedure sedation?
Etomidate 0.1 to 0.15.
0.1 mg per kg is what we usually give. Bolus doses is also 0.05 to 0.1 mg per kg is what we give as etomidate. What is the added advantages of etomidate? Ultra fast acting.
Ultra fast acting.
Patient goes into sedation within 30 to 45 seconds, isn't it? And very short acting. Usually patient comes out of sedation in
5 to 15 minutes.
5 to 15 minutes. That means any procedure that lasts more than 10 to 15 minutes, you should be ready with a second dose of etomidate. Okay. Okay, so etomidate. Good thing is cardio neutral, brain neutral. So don't have to risk of any hypotension, tachycardia, bradycardia episodes. And doesn't affect respiratory efforts. So that is one added advantage of etomidate. What is other drug? Propofol.
Propofol. If there is any musculoskeletal, if you are planning, sometimes etomidate has side effect of myoclonus. So in that cases, we can think of propofol. And also, if there is a patient is having a critical illness, as in sepsis or any major trauma, then in that case also we should avoid adrenal suppression. So in that case also we can opt for propofol.
Propofol. Okay. So what is the dose for propofol?
Propofol we give 0.5 to 1 mg per kg.
Yes, 0.5 to 1 mg per kg propofol. What is the bolus doses? Repeat bolus doses.
Also 0.25 to 0.5.
Yes, half of what we give as bolus can be used for repeated bolus. What is the added advantage? Like etomidate, faster action, shorter action, and near complete cooperation of the patient. Patient will be completely under the drug and will have absolute cooperation from the patient. Good amnestic activity. Patient will not remember about the procedure or any bad effects of the procedure as such. So good amnestic activity. What is the negativity?
Also be given in liver and renal dysfunction.
Yes, it is not dependent on metabolism of hepatic and renal metabolism. So it is safe to be given in CLE and CKD patients. What is the negative effect of propofol? Like etomidate, what is the negative effect?
Cause hypotension and respiratory depression. Because
higher doses causes direct respiratory suppression and it can cause refractory hypotension. But the doses that we give usually is too low to cause that. But what is along with etomidate? What is a negative effect etomidate has? It requires like midazolam, etomidate, propofol. It requires not only vomiting. It requires another drug for analgesic action. It's not a single drug. You have to give combination drugs for analgesic action, because all these are sedatives and amnestic activity only. There is no analgesic action. So can you tell me one drug that has good analgesic activity?
We said earlier fentanyl is there, then ketamine can also.
Yeah. Fentanyl, opioids as general has good analgesic activity. Problem with that is when you want sedative activity from opioids, you have to require a very high opioid dose to achieve sedative activity, and that itself can cause direct respiratory suppression. So usually opioids is not given as a single drug for procedure sedation, but ketamine is there. So what is the bolus dose of ketamine for sedation?
Ketamine we can give 1 to 2 mg per kg.
Okay. Now ketamine has a property. Ketamine has dose dependent variations. So ketamine can be used as a analgesic alone. That is a dose of less than 1 mg per kg ketamine. 1 mg per kg, less than 1 mg per kg ketamine is used as a analgesic alone. It doesn't have sedative properties. Then from 1 to 2 mg per kg, patient suddenly goes into dissociative state. But that varies from patient to patient. So that is not predictable at what dose patient will go into dissociative state. But usually within 2 mg per kg, patient will be in dissociative state. And in procedure sedations, what you are trying to achieve is in dissociative state, not sedative state. And repeat boluses of ketamine is only needed to prolong the duration of dissociative state, not to intensify it. So if you want to increase the intensity of sedation, the initial bolus itself should be a higher dose, not multiple doses. Multiple doses keep the patient in dissociative state. Okay. Now more than 2 mg per kg, ketamine goes into sedative classification. So ketamine has multiple roles in multiple dosages. So more than 2 mg per kg, ketamine is given as a purely sedative agent. So for a 60 kg person, more than 120 mg, we can say the patient is sedated. Otherwise, it's in dissociative anesthetic condition. Okay. So ketamine, what is the advantage? Single drug. You really don't want multiple drugs for analgesic, amnestic and sedative activity. Ultra fast acting like etomidate and propofol, action is within 60 seconds to 75 seconds patient goes under. And only problem is, other than etomidate and propofol, ketamine takes much more longer time for the patient to come out. Instead of 5 to 15 minutes of duration of action, ketamine has an action of 30 to 25 to 40 minutes of action, but that depends on metabolism. So in metabolism, ketamine's metabolism differs from patient to patient, not according to comorbidities. There is no hepatic and renal activity for ketamine, so it is safe in CLD and CKD patients. But ketamine's metabolism is very high in children. So if you are going to use ketamine for pediatric children, the duration of action will be much more shorter than adults. And if you are going to use it on elderlies, the duration of action will be much more longer than adults. That is, metabolism of ketamine is higher in children and lower in elderly. So doses should be adjusted accordingly. What is the negative effect of ketamine?
Can cause hypertension, tachycardia.
Yes. So risk of cardiac events should be kept in mind. In elderly patients especially, already existing CAD patient, already existing arrhythmia patient, ketamine should be used with caution. It's not contraindicated, it's just that you need caution to be used with. Rather than bolus ketamines, if you give small amount of boluses over a period of time, all the complications of ketamine can be managed. But what is the much more important contraindications of ketamine, relative contraindications for ketamine?
Relative contraindication, IC bleed.
IC bleed. Patients having known intracranial pressure increase, known
ICP.
cases of raised ICP, ketamine is not ideally given. There is theoretically it is proven that ketamine will rise ICP, but there is no practical evidence to support it. All the newer studies have told that up to 2 mg per kg ketamine doesn't make significant rise in ICP. But even then, theoretically, ICP rise is a contraindication for it. What else? What is another condition that usually we don't ask the patients before giving ketamine? Ketamine rises heart rate, BP, ICP, and one more.
Glaucoma, intraocular pressure.
Yes, intraocular pressure. We usually don't ask any patient, do you have glaucoma? But when you are giving ketamine in elderly, glaucoma history is very important, because glaucoma, IOP pressure will definitely increase with ketamine, and it is proven. So glaucoma history should be asked. Okay, so negative effects of ketamine is over. What is another negative effect of ketamine which is well known for everyone, which is why ketamine is not commonly used? Emergence phenomenon. Emergence phenomenon, right? Ketamine. So ketamine, once sedated, when the patient is coming out of sedation, if the patient gets a nauseous stimuli, patient goes into hallucinations, vivid hallucination, which is called as emergence phenomenon. So theoretically, you can give small amount of midazolam, benzodiazepines, any brain sedatives, very small amount of brain sedatives to prevent the occurrence of emergence phenomenon. But emergence phenomenon's incidence is pretty low when you are giving ketamine in a non-sedative doses, or if you make sure the patient is in a calm environment when he is coming out of it. Avoiding nauseous stimuli is the best thing. Other than that, in pediatric age group, emergence phenomenon is very, very unlikely. Emergence is much more common in elderlies, not elderlies, in adults rather than in pediatric age groups. So really, emergence phenomenon as a negative effect of ketamine should not prevent you from using ketamine as a viable drug. Okay, so we have talked about the most common drugs, but there are many newer drugs. There are newer ramifentanil is there. There is newer versions of midazolam, means benzodiazepines are there. Dexmedetomidine is there. But dexmedetomidine, what is the problem with dexmedetomidine for procedure sedation in ER? What is the advantage of dexmedetomidine?
It can be used for a prolonged periods. How much time we need the sedation, that much time.
Yeah. So basically, metabolism is non-dependent. So drug is actively metabolized. So it is very, very short acting. So you stop the drug, patient comes out of the sedation as soon as possible. That is the advantage. Second thing, it is arousable sedation, right? Patient is arousable. What is the negative effect of dexmedetomidine?
Bradycardia, hypotension.
Yes, bradycardia and hypotension, especially with bolus doses of dexmedetomidine, which is the initial treatment is bolus of dexmedetomidine followed by dexmedetomidine infusion. So the bolus can cause significant bradycardia and hypotension. That is one negative effect of dexmedetomidine, which can be avoided if you don't give bolus dose of dexmedetomidine. But if you don't give bolus dose of dexmedetomidine, what is the issue? What is the problem? If you don't give bolus, you can't predict when the patient will be sedated. The IV infusion of dexmedetomidine will not give a rapid sedation for the patient. Patient may be sedated even after hours. So predictability of using dexmedetomidine for procedure sedations is very difficult, because patient may not be sedated when we want the patient to be sedated. But for planned procedures, dexmedetomidine is very good. For example, you want to do a planned colonoscopy. You know when the colonoscopy is going to happen. So accordingly, you can start dexmedetomidine way earlier and prepare the patient and keep for procedure. What is the negative effect? Another negative effect. As we told, dexmedetomidine is awake sedation. That means you give a stimuli, patient will be awake and responding to you. It will not cause permanent or persistent neurological suppression. That is the main problem, because we want patient not to awake during the procedure. You are going to inflict pain. So if a patient is going to wake up to pain, then we can't use that drug for procedure sedation. That's why Dutchman, but Dutchman has multiple other uses for planned procedures, OGD-scopies, colonoscopies, but not for painful procedures like fracture reductions, shoulder dislocation. Central line insertion, dexmedetomidine is a good one. Arterial line insertion, dexmedetomidine is a good drug as such. But other than also, there are multiple newer medications that is coming up. Another one is combination of medicines. That is, for synergistic activity, people mix and match drugs to achieve optimum effort with minimal complication. One of the most famous one is ketofol, ketamine with propofol. So, propofol being a good amnestic activity will cause significant brain sedation, minimizing emergence phenomenon of ketamine. Propofol's bradycardia hypotensive episodes will be mitigated by ketamine due to its tachypneic and respiratory activity. So propofol will cause respiratory, will not cause. If at all, propofol's action is respiratory depression. Ketamine is respiratory stimulation. Similarly, propofol's being hypotension, ketamine is hypertension and tachycardia. So basically, it mitigates each other's negativity and synergistically improve patients' sedation, making the total duration of both drugs to be lowered. So ketofols, what is the dose for ketofol? Each drug is given at
1:1 ratio,
1:1 at 0.5 mg per kg. So instead of ketamine giving at 1 mg per kg to up to 2 mg per kg and propofol giving at 0.5 to 1 mg per kg, you can decrease both drugs to 0.5 mg per kg. So faster action, shorter action and lesser complications. So ketofol is nowadays primarily used in ER for fracture reductions and shoulder reductions, because complete patient cooperation will be available. So these are the main things of procedure sedation as such. Always, if at all you do procedure sedation, the patient went into mild respiratory suppression like activity, you felt that patient's respiratory efforts are low or decreased, will you say that was a failed procedure sedation? Because ideally, when we told initially procedure sedation is to achieve the analgesic anesthetic activities without compromising cardiopulmonary. But this patient requires nasal airway placement or maybe some amount of back mask ventilation. Do you think that was a failed procedure sedation? No. So mild respiratory suppression, which doesn't require prolonged efforts, should not be taken as a failed procedure as such. Should be taken as a part of procedure sedation. And it should be considered failure only if you have to go for intervention, that is intubation. Okay, otherwise it should be taken as part of procedure sedation as such. Okay, anything else? All this we are talking now. What is one of the most safest drug that you can use in ER, in which you really don't have to worry about dosage, you really don't have to worry about complications, which will act very fast and patients will come out of it ultra fast, and it can be used for a variety of procedures as per patient's need? Any drug? You understood the question, right? Do you know any drug which is very safe to be used in ER, which can be used in very multitude of conditions? Dosages is patient regulated. You don't have to regulate. The patient regulates the dosage. Patient goes under the sedation very rapidly. Patient gets out of the sedation very rapidly. Very minimal side effects.
Nitrous oxide.
Nitrous oxide. Nitrous oxide is very safe, very cheap and very easily usable. But the thing is, nitrous oxide usually in hospitals is given in central circuit, not as a refillable tank. Because of that, usually EDs don't go for nitrous oxide and consider nitrous oxide as an anesthetic compound alone. But that is one of the good drugs that can be used in ER. And there is one portable nitrous oxide brand is available, Entonauts. Entonauts is basically a refillable small tank-like thing. It doesn't have the circuit and all. Usually for nitrous oxide, you need a circuit. Breathing circuit is required to connect to the central circuit and regulate to the patient. Here it's just you can hold it in the hand. There's a mouthpiece and a mask. You just ask the patient, whenever you want the patient to go for procedure, you just ask the patient to keep it tightly in the face and press the release button. They can inhale as they require when they feel they are sedating or analgesic effect is there. You can do the procedure, and as your patient is coming out, if patient starts having some amount of pain or some response to your procedure, just ask the patient to take a couple more breaths and patient will be. We don't have to think about all the respiratory depressions, cardiac instabilities and all those things. Very safe, very short, very rapid action. But unfortunately not very commonly available. Yeah. Anything else?